This is the summary of diuretics for your board practice. We have to learn 6 classes of drugs, about 12 major drugs. It is important to compare this with a nephron structure so that it is easy for you to remember. So first class, SGLT2 inhibitor or sodium glucose transporter inhibitor. The site of action is at the proximal convoluted tubules S1 segment. Okay, before that, first 3 classes, site of action, I want you to remember as proximal convoluted tubule, okay, mainly. So, SGLT2 inhibitor, drug name Empagliflozin. Gliflozin is a class name, another name for that group of drugs. But just remember, Empagliflozin is a drug name, SGLT2 inhibitor, site of action is S1 segment of proximal convoluted tubule. Okay. Second class, carbonic anhydrase inhibitor, drug name Acetazolamide. That's target is also, the site of action is at the proximal convoluted tubule. Osmotic diuretic Mannitol, site of action mainly, that is the major action is at the proximal convoluted tubule and also to the descending limb of the loop of Henle. Throughout the nephron it works, but just remember the proximal part so that these 3 drugs in single drugs in classes, it will be at a side. Reason, loop diuretics and thiazides are the major drugs for your cardiovascular and renal symptoms you are going to prescribe. Therefore, that is going to be the most commonly prescribed diuretics also. So, we are going to focus on those, and also there are some potassium sparing diuretics there. Okay, so let's do the loop diuretics. I want you to remember 4 drugs. Out of that, 2 of them are most commonly prescribed. One is super important, very commonly, that is furosemide, then torsemide, then ethacrynic acid, and bumetanide. How I remember is, I'll remember the loop, the running of that turtle and bunny, tortoise and bunny. They are looping around, furious tortoise or something like that you can remember, so that you will easily remember. So furious tortoise and bunny looping around with the echidna, something like that. Okay, so I will talk about that. Then anyway, loop diuretics, 4 drugs, site of action is at the number 4, ascending limb of the loop of Henle. Then thiazide diuretics, there are 4 of them, but 2 are commonly used. One and is very important drugs. Hydrochlorothiazide, easy to remember. Thiazide, drug name Thiazide, it has a hydro and chloro groups. Okay, so thiazide and thiazide-like diuretics are the next 3. That is Chlorthalidone, Indapamide, and Metolazone. But just remember as thiazide diuretics so that it will be easy for you to study. So Chlorthalidone and hydrochlorothiazide, site of action is at the distal convoluted tubule, specifically early part of the distal convoluted, but don't worry, just remember distal convoluted tubule. And the last one, 6th class, it has 2 subdivisions we're going to discuss in the next page. But just remember, potassium sparing diuretic, site of action, of course it will be a little bit in the distal convoluted, but just remember mainly principal cells and the collecting duct. So 6 areas of your nephron. I want you to draw, sketch and label and write this drugs so that it is easy. And now I'm going to explain very quick way to study indication, mechanism of action and adverse effect together. So let's look at with that picture. Okay, before that, you have to look at another way. I'm going to talk about why these drugs will be different, right? So for instance, we will start from this side at that collecting duct of the nephron. So collecting duct, there is only about around 3% water is going to be reabsorbed, right? So elimination also that much if you are using the drugs using targeting that area. For instance, if you have to use that potassium sparing diuretic, the target is to reabsorb potassium and not that heavy diuretic effect. Of course, it has only mild diuretic, so you can understand there is only little bitty water left to reabsorb. So mild diuretics, these four, all of these are targeting at that area. The major aim is to reabsorb potassium, spare potassium. Very good. But how do you distinguish these two? First two are the steroid drugs targeting the aldosterone receptor. We will talk about it. But the last two are non-steroid drugs. Anyway, all those targeting that mild diuretic effect. Okay, sodium will be removed also. Very good. But thiazide diuretic, if you go little bit forward, the distal convoluted tubule, you are losing only about 5% of water. That means little more. That is enough for regulating blood pressure. That means you don't need to pull all the water out, but if it is really low level of water, that's not enough either. So thiazide diuretic is the standard first line therapy for hypertension. Uncomplicated, we will talk about it. Anyway, so most of these drugs will be combination therapy. We will talk about in the next page. But understand, thiazide diuretic site of action is right here. So that means we are pulling enough, not too much, but enough drug to regulate blood pressure. But when you think about a person with a edema, pulmonary edema or leg edema, edema in the extremities, you need to pull little more water. That means from the blood vessel and the tissue spaces. That means it has to be little more stronger, loop diuretic. That is the reason. See, we are going to target that right there. About 25% of water will be reabsorbed in that side. That's where we are going to block. Another easy way to remember, for the collecting duct, this potassium sparing duct, only the very easy small channel sodium, we will talk about that, ENaC, that's the name. Epithelial sodium channel blocker. But can't understand, sodium channel is the really one blocked by all the four, but the first two are mediated by aldosterone or mineralocorticoid receptors, but the last two are only targeting directly to the sodium channel, ENaC. Okay, anyway, just understand sodium, that's all it needed to remove 3% of fluid. That's it. That's all you need to understand. Sodium will be gone, water will be accompanying. But if you think about thiazide, that need little more. So there the target mechanism of action, the receptor name is sodium chloride cotransporter, also called symporter. It's okay, just understand sodium chloride cotransporter. That means little more fluid is going and minerals. The next one I was talking about, the loop diuretic, about 25%. Also the transporter is really stronger one, removing sodium, potassium, 2-chloride transporter. Very good. So this way you will be remembering things. But these are the drugs we can prescribe for patients to take a longer time. It's okay, because we are losing things, especially mild doses. It's fine. Of course, there will be some of the adverse effect we are going to discuss. But if you compare that side with the other side, especially one of the drugs, Mannitol, that will be the osmotic diuretic. If you think about a specific indication, your brain, if you have a injury in the brain, maybe after the neurosurgery, or like to avoid fluid filling in your brain, or cerebral edema to avoid, you need a drug which can pull maximum fluid out. That means it has to pass through the blood-brain barrier. The pressure has to be really strong. So that is the reason we are using that drug that is entirely different, IV drug. So that is going to target at this side. That is about 65% of water is the one reabsorbing in that side. That's going to be removed to, that is entirely different indication. Just understand this one. Then we will go through each drug and complete whatever you're supposed to know for the exams, for the board exam and the clinical practice. That's what in the up-to-date way we are going to discuss in the next page. Okay, this is the one nephron and we are going to distribute all the drugs here. Like I said, when at the end of the nephron, you get a gentle pull, fluid removal. Little more stronger pull will be through the ascending loop of Henle, and anterior part will be specialized stretches. So let's look at that. Okay, first one, this is how I remember. You can remember whichever way you like. I have a friend named Empa. That drug name is Empagliflozin. Gliflozin is a class name actually. Okay, so Empa loved to steal salt and sugar. She eat everything from the kitchen. So the site of action, S1 segment of the proximal convoluted tubule. Okay, very good. So why is it named gliflozin? Glucose transporter. That's how scientists named it. Sodium glucose transporter 2 inhibitor. They inhibit so that sodium, some salt will be gone, sugar will be gone, right? Everything is eliminated through the urine. This drug will be very good for hypertensive diabetic patients. So indication is unique, very good. Not too much diuresis at all. This is selectively. So we are going to get rid of some of the glucose also. That is the reason patients will develop, like if it is especially elderly patients for long-term therapy, patient can develop a risk for UTI will be very high because of the presence of glucose there. Understand? Mechanism of action is the one I put it in the class name, sodium glucose transporter inhibitor. Anyway, drug name Empagliflozin. That's good. Second class, my friend went into mountain climbing. Okay, the patient comes with a mountain sickness, or before going to mountain climbing, they can take the the altitude sickness prophylaxis. Why? Actually, what it is doing is, this drug, whatever we are discussing, the site in the proximal convoluted tubule, this is going to work at the carbonic anhydrase enzyme. So the carbonic anhydrase inhibitor is the drug class. The drug name is Acetazolamide. This drug works on the proximal tubule area. This is going to help to increase potassium ions, hydrogen ions or the protons in your blood, and increase metabolic acidosis. That means if a patient coming with a metabolic alkalosis, you can use it. For instance, we are going to discuss in the loop diuretic and thiazide diuretics. One of the characteristic adverse effect is metabolic alkalosis. So in case if you the patient coming with that, you can add this drug acetazolamide as an add-on therapy. Otherwise, just mostly loop diuretic has more conditions, so you can add it with it. Anyway, understand mountain sickness and all those you can use it, right? Sometimes glaucoma, different thing. Just study one indication, okay? So acetazolamide, mechanism of action is super important. Carbonic anhydrase inhibitor, and adverse effect is also important because it will retain proton, eliminate a lot of bicarbonates. Therefore, it develops too much metabolic acidosis in the blood. So metabolic acidosis, that's how I remember. Acetazolamide, acidosis. Metabolic acidosis is an adverse effect. Very good. We are done with the two drugs. Then the third drug, my friend came back. She fell down and broke her head. So I'm going to put a patient for cerebral edema. Very easy. Don't spend too much time to study that drug. Mannitol, by special like a mechanism, this is actually creating a powerful osmotic gradient, massive diuresis by working at a proximal convoluted tubule and at the descending ascending limb. But anyway, just remember this area, this is going to work and pull component by osmosis. That is why the drug class name is osmotic diuretic. Drug name is mannitol. This is an IV drug. Think about it. If a patient has cerebral edema, I cannot wait for giving an oral drug and take hours to work, right? You need to really do it, don't wait for that. So that's why we are using IV drug for that. Of course, other drugs IV are available, but just don't worry about it. Just focus on that one. Okay, now the real heroes. Next section, the number 4, ascending loop of Henle working drugs are, maybe Mannitol. I forgot to mention an adverse effect. Just remember one adverse effect, because it is pulling a lot of water out. It will cause dehydration in patients. Okay, next is loop diuretic. Okay, my friend came back after 10 years with her husband. My friend has a edema at extremities, or you can put her for pulmonary edema, very good. And her husband has congestive heart failure, right? Like fluid overload. Heart is so tired, it cannot pump, so you need to reduce fluid overload. That is why the loop diuretic is working very well. Even for the chronic kidney disease, you needed that because kidney cannot function, you can use it. But just understand these two. So the class name is loop diuretic. Loop diuretic work at the ascending limb of the nephron, and furosemide is the most commonly prescribed. You can give it for any of these conditions. But to study, just remember for edema, I am going to give my that lady, that Furosemide old lady or man, whoever, and the other person, heart failure, I am going to give Torsemide. There is a specific reason for that. If these two drugs are available, Torsemide has proven effect of cardioprotective effect in addition to the normal functioning, that is the normal diuretic effect. That is the reason Torsemide is comparatively, compared to furosemide, recent evidence-based clinical studies proved that Torsemide is comparatively positive benefit on heart or cardiac patients. Okay, so furosemide and Torsemide. Let's look at that one more drug. These two drugs are sulfur drugs. Therefore, the next drug, they don't have any sulfur link structure in their structure. Therefore, there is no sulfur allergy. If the patients have sulfur allergy, you can give that next drug called Ethacrynic acid. Okay, let's look at the first drug, furosemide. Okay, this furosemide actually working, all these loop diuretic work in the exactly same mechanism, targeting sodium, like I said right here, sodium, potassium, 2-chloride symporter or transporter. This is going to block. Therefore, that's important. I want you to remember 7 components to remove. First, your aim is to remove water. Number 1, water is gone. Okay, very good. Then sodium, right? Water, sodium accompanied together. So the sodium, you don't even have to remember. You just remember the mechanism of action, which transporter. I have sodium, potassium, chloride. So all the 3 is removed. Sodium, potassium, chloride. Then with a different transporter nearby, because of this mineral distribution difference, there are calcium and magnesium elimination also happen, and hydrogen ion proton elimination. That means total 7. Water, then the mechanism of action is sodium, potassium, chloride. So sodium, potassium, chloride, then calcium and magnesium, plus proton. Remember, if you lose all the hydrogen ions, one of the adverse effects is metabolic alkalosis. If you lose a lot of potassium, you will get like hypokalemia, hyponatremia. All these are the adverse effects you can have, right? Hypocalcemia, all this. Just understand mineral loss is a major one. And you need to save the patient. If the patient is coming with edema, you cannot just not to treat, right? So you have to. So, but that will be like a moderate dose and all. Anyway, so adverse effects. So we already discussed major adverse effects, and a loop diuretic second drug was Torsemide. I told you same 7 components are removing, but in addition to that, it has one more point I want you to remember. In the cardiac muscles, this has a specific function on the fibroblast cells. In the fibroblast, it can easily get into the fibroblast and inhibit the collagen synthesis. Sorry, not collagen. The collagen activation and the fibrosis is the major function, right? So the fibrosis will kill the fibrosis formation will kill the cardiac muscle. That will be inhibited by torsemide. That will be a very selective point I want you to remember. That will be useful for you. Okay, what if my patients have a sulfur allergy? Okay, you have a drug called ethacrynic acid. Ethacrynic acid, only thing is sulfur allergy patients can use it, but all the 3 loop diuretic can have mild ototoxicity hearing problem, but later it will be managed. But if it is a higher dose, of course that will be a complication. But out of all these drugs, ethacrynic acid has a ototoxicity adverse effect main. Even if I get like a furosemide mixed with ethacrynic acid is the one you're supposed to pick. But reason I remember, like ear ethacrynic acid ototoxic. Let me tell you the reason. Everything, if you know the mechanism of action, that's it. Mechanism of action of loop diuretics, what is it? It will block the sodium potassium chloride co-transporter. So in my ear or in the inner ear cochlea, there are hair cells. These sensitive cells also have exactly same sodium potassium chloride transporters. Ethacrynic acid can easily distribute it into my inner ear and block exactly similar way. It will block my sodium potassium chloride channels in the inner ear hair cells. Therefore hearing problem can be there. Okay, understand ototoxicity is severe in this drug because of the unique structure. It can easily diffuse into the air. Okay, the other drugs are slow diffusion. Okay, we are done with this section, and then let's look at the thiazide diuretic. Okay, after maybe 5 or 10 years, my lady friend came back with a hypertension. She brought her grandma and grandpa. Okay, her grandma has osteoporosis. Her grandpa has kidney stone, the renal stone with a calcium containing calcium phosphate and calcium oxalate containing renal stone. What is our aim? So let's talk about this blood pressure. You need to remove some fluid from the body and with the sodium and all, and regulate it, because blood pressure is super important. Because if you don't have blood pressure, our brain will not, when we walk around, our brain will not get enough oxygen. So blood pressure is so important. So it has to be very gently controlled. So this drug is very gentle enough to regulate the blood pressure in certain doses. So the class name is thiazide diuretics. Thiazide, the drug name also has thiazide here. First drug, hydrochlorothiazide. There is a chloro and hydro groups there. Hydrochlorothiazide is a very mild, gentle and a very effective drug. But compared to chlorthalidone, let's stop there. True thiazide diuretic, because of the structure, don't worry about it, that is the hydrochlorothiazide. Chlorthalidone and other groups of drugs in this class is called thiazide-like diuretic. That doesn't matter. This chlorthalidone and hydrothalidone, just study single mechanism of action, adverse effect, all this, everything is good. Okay, so but I want you to understand, if you have to pick a drug, chlorthalidone people pick it because it's a strong, potent drug, work really well for blood pressure. But one problem is patients can get secondary metabolic condition disorders and all. Reason, chlorthalidone is very strong with a longer half-life. Therefore, it has a more severe adverse effects than hydrochlorothiazide. That is the major reason. Maybe because of the the not advertising, like how it will be. It's like a business, right? Anyway, so hydrochlorothalidone is most prescribed than chlorthalidone, but effective wise, chlorthalidone is a strong drug. Okay, let's finish it. So here, the mechanism of action, in the distal convoluted tubule, sodium chloride transporter inhibitor, very good. So chlorthalidone or hydrochlorothiazide, this can block, but when you block that transporter, you will remove all those like loop diuretic except calcium, because there is a sodium calcium exchanger, that's going to be blocked by these drugs. Therefore, calcium will be reabsorbed into the blood. Calcium is not removing. That means, let's review that 6 component. What is removed from this distal convoluted tubule? Easy to understand. Of course, water is going. Sodium chloride, sodium going, chloride going. Of course, potassium is also accompanying going. Of course, the receptor is not the one, different receptor, but little bit different mechanism. Potassium going, then magnesium and hydrogen ion or protons. Those will be leaving but reabsorbing all the calcium. Oh, that is very good. If I have an elderly patient with osteoporosis, I can give these drugs so that they will, oh, what does that mean? It is not an osteoporosis treatment. All the cases I am discussing is somehow they need a diuretic. Okay, don't confuse. Okay, the patient has some cardiovascular or some risk problems, we need to prescribe a diuretic, but you have that patient has a osteoporosis condition, then you don't want to prescribe this loop diuretic. I can pick that thiazide diuretic. Therefore, there is a protection. Very good. We indicated as a first line for blood pressure, like a initial treatment or the primary or the essential hypertension. We can use hydrochlorothiazide and chlorthalidone. Very good. Then chlorthalidone, another indication is these drugs can reduce calcium elimination into the urine because it reabsorbed. Therefore, it is not removing through the urine, not peeing out, it is absorbing. Therefore, if a patient has a history of calcium containing stones, the patient has to take the thiazide diuretic. Out of all the diuretic, that is a good one because they don't pee calcium. The risk of calcium containing stones will be reduced. Hope you understood. I think we covered most of the topic in that section. And the next one, last one is the potassium sparing diuretic. Where are they working? At the collecting duct. Of course, at the end of the distal convoluted tubule there, but don't worry about, just study as collecting duct and mainly principal cell. It's easy for you to understand. Okay, what you have to understand is potassium sparing drugs have 2 classes. One is MRA. What does that mean? Mineralocorticoid receptor antagonist. That is aldosterone mediated sodium removal and water removal. Okay, stop right there. Spironolactone and Eplerenone, both drugs are steroid drugs. They can bind on the aldosterone receptor, that is mineralocorticoid receptor, and block aldosterone's function. Aldosterone mediated sodium loss will be blocked. How are they indirectly blocking? They indirectly stop producing a sodium channel, or they stop recruiting that sodium channel, so that you will be controlling. In return, we are going to reabsorb some potassium. Therefore, this is a potassium sparing drug. Very well. But mineralocorticoid receptor, I wanted to distinguish these two also. Spironolactone has non-specific adverse effect. Reason, this can bind because of its unique structure. This can bind and block the mineralocorticoid receptor. Also, it can bind on the progesterone receptors and androgen receptors and all. Therefore, if I am giving to a female, some of the menstrual problems she will be having, and if I am giving to a male, they can have a gynecomastia, like all those problems. Of course, we will learn this drugs. I think I already uploaded another lecture for the glucocorticoid mineralocorticoid lecture. In that section, I believe I explained spironolactone very well, because that lecture has a major role to explain. But for the diuretic, I want you to remember the mechanism of action, where the site of action, how do you distinguish this potassium sparing drug, like this hormone mediated potassium sparing drugs. That is specifically, the term is steroid type of drugs, with the non-steroid drugs, right? So I want you to remember that. So spironolactone mechanism of action, you understood, the blocking that mineralocorticoid receptors. They are called mineralocorticoid receptor antagonists. And don't worry about that picture. We cannot treat these like a, what do you call that word, muscle cramp or anything with the eplerenone on these drugs. But way I put it is, muscle cramp, usually you know that it is because of the potassium loss. So what this case I remember is, my friend came back with her husband. Now her husband has ascites, that's a term, ascites because of his cirrhosis. Cirrhosis mediated or induced ascites. Spironolactone is a very good drug to treat that. Of course, the other drug is also effective. The second, she comes with some side effects of other drugs. She has hypokalemia. So I just remember hypokalemia with that. That's the only thing. But don't confuse with that picture, okay? So we can use these two drugs to treat that patients. Of course, these are interchangeable. But just to study one indication and drug name, that's how you start the first step. You're supposed to memorize all these, so it's an easy step, okay? Hope you understood all those parts. Then let me talk about the next group of drugs. Then after, I don't know, a couple of years, she came back with her daughter. So her daughter is now pregnant. I have to treat her for hypokalemia. Some, she's taking some other drug or something, potassium absorbing, reabsorbing drug, and also she has some potassium loss. What if she doesn't want to take, remember, we gave Eplerenone, right? But she doesn't want to take any of the steroid drug. We can give Triamterone. Also, pregnant lady, we can give Amiloride. I'll tell you the reason. Pregnancy, usually we can prescribe Hydrochlorothiazide. It's okay. And also, during pregnancy, it is not a good idea to give thiazide, right? But if you have a hypertension and all, most of the, I will explain that in the tomorrow's lecture. So, hypertensive drugs are contraindicated in pregnancy because of the teratogenicity. Therefore, we may need to stick with some of these thiazide in some situations. In that case, most of the other thiazide is a no. We don't want to go for, of course we can, if it is really required, you know that. But otherwise, old classification, pregnancy category B, 2 drugs. If you can remember with that, you will add it with that. Usually, I remember 12 drugs with a 12 indication so that it will be done. Then you add on different points, okay? Hydrochlorothiazide also can be, because that's an O. Compared to Amiloride, most studies done with that, it is okay. Keep in mind, both of these drugs, Amiloride also pass through the placental barrier. But in the animal studies, there is no indication of any embryonic damage. That is the reason it is okay. Okay, we don't want to spend much time. Triamterone is the other drug we were talking about. Okay, let's talk about the mechanism of action, then we will be done. What is the difference of the MRAs and ENaC difference? Okay, keep in mind, all the potassium sparing diuretic work in this site. Final target is sodium, that ENaC, epithelial sodium channel blocker. But the first 2 drugs are exclusively changed or considered as MRA, mineralocorticoid receptor antagonist, or aldosterone receptor antagonist, right? Why is it called? Because aldosterone mediated sodium channel blocking is the one. Because, aldosterone is the one determining, we don't need much sodium channel or anything. So, sodium channel will not be produced or sodium channel will not be recruited. So, aldosterone has nothing. They just don't even think about sodium channel in that step. So therefore, if I am giving all the 4 drugs for what is the real mechanism of Triamterone, you can say ENaC blocking or Amiloride ENaC blocking. If I am asking about spironolactone in the choice, I don't have to talk about ENaC blocking there, because spironolactone and eplerenone is directly inhibiting the hormone, aldosterone, mineralocorticoreceptor inhibition, but after all, potassium sparing diuretic work on that sodium channel. Why I am teaching like that is, this is the only way you can combine all the drug in a one chain. Okay, so understand, epithelial sodium channel blockers, specific that channel blocker, they are actually going to plug and block that channel, and therefore you don't want to worry about like we were talking about 3% fluid will be gone, sodium will be eliminated. In return, potassium will be reabsorbed, enough potassium to maintain our body's conditions. Okay, understand? I think that's all we have to remember. So we were discussing the first 3 classes targeting in the first half of the nephron. That's how easy for you to remember. One drug each and one specific indication. But the first one, you will see that's a new drug, and it's a very good class of drug with very mild adverse effects and very effective. Maybe when you become physician, this is going to be the super drugs in the future. Reason? Both cardiovascular and diabetic protection. Very good drug. Then the next 2 classes we were talking about site of action. Number 4, ascending loop of Henle, Furosemide, Torsemide, Bumetanide and Ethacrynic acid loop diuretics, and Thiazide diuretics at the distal convoluted tubule. Remember, the receptor will be entirely different, right? Sodium chloride co-transporter will be blocked at the thiazide, but the loop was sodium potassium chloride importer or co-transporter, and the last one, potassium sparing diuretic, site of action will be mainly collecting tubule principal cells. And I think I explained very well. Hope you understood, and this may be helpful. Thank you. Bye.